How long do you suppose a person has to have symptoms before we give them a diagnosis of depression? Any guesses on that figure? How long?
6 months? 6 months is what the guess was.
2 weeks. 2 weeks of consistent symptoms. They're saying that if, well, I'm going to tell you about the symptoms. But the two major questions that have to be asked about those 2 weeks are, have you felt sad or hopeless in the past 2 weeks every day? Have you felt little pleasure or interest in doing things that you normally would be interested in for the past 2 weeks? Again, some more statistics before we go further into that is that 10 to 14 million persons in the United States are experiencing depression in any given year. Now, one of our dilemmas is, and that's 17 to 20% of the total population, but 25% of those patients stop their antidepressants within 1 month. 60% stop their antidepressants after taking them for 6 months. So what we end up with is another period when these patients are going to have another episode or a relapse before they're going to be diagnosed again. So according to the DSM-4-TR, the diagnosis for major depression is that 5 or more of the following symptoms have to have been present during the 2-week period and represent a change from previous functioning. At least 2 of the above have to be the 2 I mentioned: depressed mood and sadness, loss of interest or pleasure. And the others are markedly diminished interest or pleasure, or I'm sorry, I mentioned that. Significant weight loss when not dieting, or weight gain, or decrease or increase in appetite nearly every day. So all of those, in those 14 days, they have to have this symptom significantly, or a 5% change in their weight over 1 month, loss or gain. Insomnia or hypersomnia nearly every day. Fatigue or loss of energy nearly every day. Psychomotor agitation or retardation nearly every day, observable by others or self-reported as restlessness or being slowed way down. So when we start to look at these things, you can start to hear that it's either too much or too little during this period. Feelings of worthlessness or excessive or inappropriate guilt nearly every day. Diminished ability to think or concentrate, or indecisiveness. And we're not talking about that walking into a room and say, why did I come in here? What am I looking for? It's really a person being able to sit and watch a television show and then a member of the family saying, what did you think about that? And they didn't pick it up, they didn't absorb or concentrate. And trying to do something they do every day, bookkeeping, or so their loss of concentration is significant. Recurrent thoughts of death, not just fear of dying, but recurrent thoughts of death. Recurrent suicidal ideation without a specific plan, or a suicide attempt, or a plan that is an active plan to commit suicide. I'm briefly going to talk a little bit about the differentiation between bipolar, but that's not basically what I'm talking to you about. I'm talking to you about the major depressive disorder. But if a patient answers yes to a couple of things, have you felt lately that you can get by on much less sleep than you used to? Or are you doing things that other people consider inappropriate, like spending too much money, deciding at 4 o'clock today you're going to be in New York by tomorrow morning, just being on a consistent high? And if there's a strong family history, then we may be wanting to look at bipolar rather than major depression. If we see patients in hypomanic phases or manic phases, it's really easy to start to diagnose those bipolar patients. But the fact is, most of the patients that we see who may be bipolar present as depressed and meet the criteria of the first 2 weeks of having all of those other symptoms. And we don't see the mania as often. So again, those are the easy ones. And the hypomanic episode must be at least 4 days of elevated symptoms. And again, she's going to talk to you about that. And the manic episode needs to be a longer episode and more exaggerated. Some other mood disorders that we see are cyclothymic, dysthymic, substance-induced mood disorders, but they are not major depression, and there's a distinctive way to find out which ones are which. I'm not going to talk to you about cyclothymic and dysthymic disorders. They're where a person feels a little put off frequently, but they don't meet the same criteria as the depressive disorder. Some of the diagnostic tools that I'm just going to mention briefly are, there's a Cox proportional hazard regression analysis test for suicide predictors, and that's a long phrase, and you and I will never have to worry about it much, but it just tells us that there are predictors of the suicide risk in these major depressive patients. The STAR-D study was a national study that was done to assess depressed patients, and the thing about it that was interesting is that it was a national study. It was multi-sited, different places throughout the United States. It was in real-world settings, so it wasn't where patients were only hospitalized or only in a setting where they could all be doing the same things all of the time. And it was and these were real-world patients who were working, were in families. Again, it wasn't where the factors were closed down to just one small group. And regardless of comorbid conditions, they weren't looking at substance abuse, and they weren't looking at other factors. It was basically just a multi-sided national study. There's a measurement-based care study that talks about relief of symptoms and side effects. It has more to do with medication. And I'll talk to you a little bit about medication too in just a moment. The HAM-D depression scale and the mood disorders questionnaire. And these tools are very, very helpful for people in this setting or in a private office. But very often when a patient comes in, they're looking for relief not in 6 weeks, not in 2 months, now. And that is one of the reasons that we're really looking favorably at some of the newer medications that are starting to impact the mood almost immediately without being a mood-altering, mind-changing, addictive substance. We don't want those, of course. One of the things that in my experience is very, very important is the multidisciplinary assessment. I find that when social work, nursing, psychiatry, medicine, all assess the patient, you have a really better informed assessment. And the reason being that patients respond differently to different people. And I'm sure you find that in the setting here with the substance abuse patient. One particular provider may really get a lot of information, whereas another person, the patient will be resistant and obstinate, won't give them any information. So I really look long and hard at multidisciplinary assessments when I go into the hospitals in particular. The other thing that I think is extremely important in assessing these patients is the focus on their subjective interview, hearing what they feel, because they know how they feel. They're the only one living in that body. Sometimes they're not able to really give us all of the information that we need, but very frequently, if you become the good listener, you are able to hear what's happening with them, how long it's been going on, and sometimes it's far longer than we would assume, because patients come to get help, and again, they usually come because a crisis has developed in some respect. Even if it's only a subjective crisis for them, that they can't concentrate anymore. They're spending long periods of time crying, that kind of thing. So hear what he or she says and that they feel. It's really important to remember the cultural differences and values, things like shame. In fact, shame can become so toxic that a patient becomes so depressed they will not tell you anything about their background. And you just have to weed that out. Remembering the cultural differences keeps an American versus an Asian versus Hispanic versus any other person from another country from giving us all the information that we need. They especially have difficulty relating to strangers about the history of their parents' behavior, poor decisions they've made in the past, sexual or drug behavior, out of control anger, disregard of others, and an inability to take care of their obligations like children. Excuse me. People who have been unable to fulfill their home duties, taking care of their kids, really develop a huge sense of shame, and they find it hard to open up. So one of our tasks is to make them extremely comfortable, and most of you already know about that. One of the third things that I think is extremely important is getting a very well documented history, medical history, substance abuse history, because we want to know, is this a diagnosis or is this a symptom? Is the sadness a diagnosis, or is the sadness a symptom of their alcohol use? As Dr. Pohl said, alcohol is a major depressant, and someone who's been drinking for a long period of time is going to be depressed. So for us to weed out whether this is a major depressive disorder and a psychiatric illness, or whether this is a symptom of their alcohol use, takes time, patience, and an exceptionally good history of whether they've ever been treated before by anyone. They may have been treated by a therapist 20 years ago because they were having episodes of crying in their teens, but no one picked up on that. Is the anxiety a complication of the depression, or is it the anxiety a complication of a medication, a medical medication, or a psychiatric medication, or a substance that they've been overusing or addicted to?